Good afternoon, everyone. My name is Jenny Bogard, and I am the Executive Director at the National Hypertension Control Roundtable. I am thrilled that you are all joining us today to hear about heart health and brain health, two sides of the same coin, understanding the results of the U.S. Pointer study. I am joined by Matthew Baumgart, Senior Vice President of Health Policy at the Alzheimer's Association, and one of our roundtable steering committee members and a dear colleague of mine. So without further ado, I will pass it over to Matthew.
Thank you very much, Jenny, and thank everybody for joining us today. As Jenny mentioned, I represent the Alzheimer's Association on the steering committee of the National Hypertension Control Roundtable. We joined back in 2022 because of the strong link between hypertension and brain health. I know there were probably some people when we joined say, why are the Alzheimer's people joining a hypertension control roundtable? But because of the strong link between hypertension and brain health, we know that addressing hypertension can help your brain health, can help reduce cognitive decline, and possibly even lessen your chances of getting dementia. And as we continue to explore that heart health and brain health connection, as Jenny said, two sides of the same coin, or the same side of two coins. We wanted to share with you the results of a groundbreaking study called U.S. Pointer, as well as an ancillary study that looks specifically at hypertension and heart issues in the Pointer study among the participants in that trial. So let me introduce today's speakers, and then we'll get right to it. We have Hassam Shaltut, professor in the Hypertension and Vascular Research Center of the Department of OBGYN at Wake Forest University School of Medicine, also the director of the Hypertension Clinical Non-Invasive Hemodynamic Core. Hassam, thank you very much for joining us. Also today, Tina Brinkley, who is associate professor in the Department of Internal Medicine section on gerontology and geriatric medicine at Wake Forest University School of Medicine. And Hassam and Tina worked on the ancillary study to U.S. Pointer that looked at hypertension and blood pressure and among the participants in the study. And then our third speaker, who will actually go first today, is Heather Snyder. She is the Senior Vice President of Medical and Scientific Relations at the Alzheimer's Association, my colleague. She was one of the co-leads on the U.S. Pointer study. So I will turn it over to her to let her tell you about the study and the exciting results.
Thank you so much, Matthew. And thank you, Jenny, and all of you for joining today's conversation. Really looking forward to the dialogue and discussion and hearing your questions and comments as we talk. And we thought that before we got into some of the specific results, it would be helpful to set the stage a little bit about what is U.S. Pointer. While I know some of us have lived and breathed it for a number of years, this might not be something that you're as familiar with, or you've heard it, but you may not know the details or the ins and outs of it. U.S. Pointer was a study that really came to fruition because one of the top questions that we get at the Alzheimer's Association is, my mother, my father, my grandmother, my aunt, my uncle had some form of dementia or some form of cognitive decline. What can I do to reduce my risk? And as Matthew outlined, there's increasing science and increasing evidence around some of those links between heart health, for instance, and brain health, as well as other factors that may be able to modify a person's risk. And so if we simultaneously target multiple risk factors in a population of people that are cognitively unimpaired but at risk for cognitive decline, what's the impact that we have on our memory, our thinking, and our reasoning? And this really leveraged a study that had taken place in Finland a few years prior, but where in Finland they have incredible access to healthcare, education. It's a relatively homogeneous population. We needed to know, could we translate that to the breadth and scope of the United States across the board, and then also bring in what we see in the what we see in our communities across the board, and also the latest in the scientific advances. So really in this context, we see the numbers of individuals that are living with cognitive decline and dementia are rising. We have really these lifestyle, this data and this science that's telling us that certain behaviors, certain lifestyle factors like poor nutrition or lack of physical exercise are linked to higher rates of cognitive decline. There have been increasing number of studies that tell us that individual lifestyle factors show promising results, but actually it might be the synergy, the combination of simultaneously targeting multiple risk factors that may have the greatest benefit for cognition and our brain health across the board. And so this was really the question that we were asking. And we did this in 5 sites across the United States. We recruited 2,111 individuals. This trial was a little bit different in that it was a true private-public partnership among each of these sites, each of these centers with the Alzheimer's Association is the community partner, among others, that engaged participants, but also delivered the intervention in the community. There were 2 different interventions, the self-guided and structured, and I'll talk about those in one moment. And the intervention went over 2 years, and we were looking and asking the question, the impact on cognition. So who did we recruit for this trial? We were recruiting individuals that were at risk for cognitive decline, but without any detectable cognitive decline or dementia. They were aged 60 to 79, did not exercise regularly, suboptimal diet. And then we looked for individuals that had 2 or more of any of these factors, which includes the cardiovascular health risk. And we used the Framingham Health Score as part of that measure, part of our ability to ask that question of what's their baseline. Now, part of this was we wanted individuals that are at risk for cognitive decline, but yet don't necessarily have any detectable memory impairments. Individuals with room for improvement, if you will, because we were looking at an intervention that was going to simultaneously target these risk factors. Who did we recruit? We recruited individuals, you can see by age across the board. We had about 31% that were from historic populations that are not included in research, and about 70%, just under 70% were female. And I think for me, one of the most striking characteristics of our participants, but also speaks to the adherence and why we had such strong adherence throughout the entire trial in both intervention groups, were over 78% of our individuals reported a family history of memory loss. So they were incredibly motivated to engage in an intervention that may be beneficial for their brain health. And this was, I think, part of the driver. We've had several participants since the trial that have reported or reported out or shared their story as being a trial participant. And this is the number one driver, is that they had been a caregiver, they had witnessed a grandparent or a parent with memory loss, and they wanted a different future for themselves, but also for their children and their grandchildren in some cases. And that was a big driver of their participation. Probably not the case for all, but certainly one of those that was there. The 2 different interventions were self-guided and structured. The self-guided had 6 facilitated team meetings over 2 years that had general support from a study navigator. Those study navigators were employees of the Alzheimer's Association. And they delivered education and general support around lifestyle behaviors that may be associated with cognitive decline, increased risk of cognitive decline, general support to encourage physical activity, a healthy diet, cognitive and social stimulation. And then every 6 months, individuals came in for blood work as well as cognitive assessments. This is in comparison to the structured intervention, which had 38 facilitated team meetings over the 2 years. There was very specific education and goal setting with accountability and support from the study interventionist and the navigator for these participants. There was a specific regimen for physical exercise, nutrition, cognitive and social challenge, as well as their guideline-based health coaching. And with that, it had a very specific number of regimens of physical exercise. The nutrition, we used the Mind Diet with a goal of getting to a specific score. The cognitive and social challenge, there was an online cognitive tool, but also it was surrounded by a number of other engagement and cognitive activities for the participants. And then they reported on those with their navigator and with their in their team meetings throughout the entire trial. As I mentioned, the outcome was really what's the impact on an individual's cognition over 2 years, their memory, their thinking, their reasoning. So cognitive assessments were done every 6 months, and it was a large number of cognitive assessments that were done. And this was in order to allow us to harmonize with past studies as well as ongoing other studies that were in a population that were not cognitively impaired, but saying, can we impact the trajectory of an individual? Key takeaways. So what you see here is, and this was published in JAMA, the paper is here. The key takeaways, the structured intervention is the top line, the lower line is the self-guided, and you can see that while both groups had an improved cognition during this period of time over the 2 years, there was a significantly greater cognitive improvement or benefit for those in the structured intervention. Now, I will note that the structured is being compared to the self-guided. There was not a true placebo, if you will, a group that received nothing, because we felt that as the Alzheimer's Association, when a group was raising their hands and saying, we want information on brain health, it wasn't ethical for us to not give them the information that science has today. And so we are working on some proximity matching and some other types of modeling out, but the study was specifically designed to really look at the difference that the support and structure has in an individual's cognition over that period of time. And there is likely some test and retest aspect here, but we can certainly talk about that in the discussion. So while both had benefits, we did see a greater benefit in the structured intervention. And this extra benefit was the same regardless of sex, age, whether an individual had the ApoE4 genotype, which is a gene that's been associated with increased risk of Alzheimer's in some populations, or the heart health at the start of the study. So regardless of where they started from their overall cardiovascular health, we saw the same benefit of the intervention during the period of time. And that structured intervention equates to nearly 2 years of slowing of the cognitive aging clock, if you will. So the individuals performed like they were nearly 2 years younger compared to somebody of their age. And again, this is only a 2-year intervention. So what's that long-term impact? And we continue to follow these participants over time in the absence of an intervention to continue to do those assessments so we can ask that question and also look at, is there a long-term impact on cognitive decline or dementia in this population? And we don't know that. That's certainly a question. What we can say is that we're able to build in some cognitive resilience or some benefit to cognition in this at-risk population of individuals. And with that, we can then start thinking about how can we translate the outcomes of a trial into the community. And so the Alzheimer's Association has moved forward with funding 12 teams across the country to think about that translation. How can we shorten that timeline of implementation from where we've seen in other disease spaces? It's taken decades. Can we do that in a much shorter timeline where we're taking a trial and we're putting it into the context of the community going forward? So now, while I've presented to you on the cognitive results and the outcomes of the cognitive results, there were also four actually different ancillary studies that were funded by the National Institute on Aging at NIH, specifically to add in imaging, taking a picture of the brain using amyloid, tau PET images, which are measures associated with Alzheimer's, as well as different MRI measures throughout the duration of the trial. We also have a study looking at microbiome and the overall gut-brain axis and the impact of the intervention in those individuals. A study that's looking at sleep and the impact on sleep and sleep fragmentation for those in the structured versus the self-guided. The sleep study has reported at a recent clinical trials meeting that they saw a decrease in the number of apnea events, as an example. And then the last of the ancillary, but certainly not least, is looking at neurovascular function. So I'll pass it back to Matthew, as I think we're going to pass it to the two PIs of that study to share a little bit of the results that we saw from that. Matthew?
Thank you, Heather. Hassam and Tina, take it away. We're very interested in hearing about what this intervention did to your blood pressure.
Yep, thank you so much. I'm Tina Brinkley. I'm going to kick us off. I am very excited to be here today to share the results of the U.S. Pointer Neurovascular Ancillary Study, or Pointer NV, on behalf of the study team, along with my colleague Hassam Shaltut. We have no disclosures to report, but I would like to acknowledge our funding by the NIA. And so I'll be really providing an overview of the study, talking about why we're even interested in neurovascular health in this population and what the goals are for this study. I'll talk about the primary outcomes of interest and how we measured them. And then I'll be handing it over to my colleague, Hassam, to present the top line results on some of the key outcomes, as well as talk about some next steps. And then we'll close with a very brief discussion of the prevalence of hypertension in US pointer and its implications for cognitive function. So the primary objective of pointer NB is to investigate neurovascular mechanisms that may underlie the effects of the two multi-domain lifestyle interventions on cognitive function and overall brain health. And this is important because there are important implications for neurovascular function and cerebral blood flow. So we know that adequate blood flow to the brain is critical for maintaining optimal brain function, and that there are key impairments in neurovascular mechanisms that regulate cerebral blood flow, which can lead to reduced cerebral perfusion and ultimately contribute to cognitive decline and dementia. There are also aging-related changes in vascular structure and function and vascular beds throughout the body that can further lead to impairment in these mechanisms. And so typically when we think about cerebral blood flow and measuring that, we think about these cool brain images that we can get from MRI. This one shows cerebral perfusion in the brain. But we know that the neurovascular mechanisms that I'm talking about and some of these vascular changes can actually precede these changes in traditional biomarkers that are observed on imaging. And so this is really relevant for US pointer participants because impaired blood flow regulation is linked to a number of risk factors, including older age, chronic diseases like type 2 diabetes, hypertension, and obesity, and various lifestyle factors such as sedentary behavior and a poor diet. And these are really the risk factors that that were highly enriched in the pointer population and we recruited participants for. So we enrolled US pointer participants with a history without a history of atrial fibrillation or a pacemaker. And then we conducted neurovascular assessments at baseline, month 12, and month 24. So we had two primary mechanisms or outcomes that really focused on these integrated neural and vascular pathways that regulate blood flow to the brain, both at the local and systemic level. And then our secondary outcomes focused on the vascular contributions to cognitive impairment and dementia, along with some other measures of autonomic function. So the goal of these neurovascular assessment visits was to measure blood pressure and blood flow and their regulation, as well as evaluate vascular structure and function in three major arteries, including the aorta, carotid arteries, and the cerebral arteries. And this really reflects the flow of blood flow from the heart to the brain. And we were able to conduct a very comprehensive neurovascular assessment using a variety of non-invasive complementary techniques, including ultrasound, ECG, tonometry, and blood pressure monitoring. Sorry, my slides don't want to advance. Oops, there you go. Okay. So we assessed autonomic function. This really measures the activity of the autonomic nervous system, which is responsible for regulating involuntary physiological functions like heart rate and blood pressure. And so we used a finger cuff coupled to a arm cuff to measure beat-to-beat blood pressure, along with a 3-lead ECG to measure electrical activity of the heart. We conducted these measurements at rest in the supine, standing, and seated positions, and in the transition from seated or supine to standing. And so we were able to assess a number of different outcomes, including baroreflex sensitivity, which is important for regulating arterial blood pressure. I'll talk a little bit more about that in the coming slides. Other measures like heart rate variability, blood pressure variability, and various measures of vagal and sympathetic activity. We also assessed the cerebral vasculature in collaboration with John Bennett and Artie Sarwal. So we use transcranial Doppler to examine blood flow within the middle cerebral arteries, along with respiratory monitoring to measure end-tidal CO2. Measurements were conducted at rest in the seated and standing position, during posture changes from seated to standing, as well as during hyperventilation and CO2 inhalation. And again, we were able to measure a number of different outcomes, including cerebral autoregulation, which is important for regulating cerebral vascular resistance. I'll talk a little bit more about that in a coming slide as well. And then a number of different measures of cerebral hemodynamics, including blood flow, velocity, cerebral pulsatility, cerebrovascular resistance, and vasoreactivity. In collaboration with Gary Mitchell, we assessed aortic structure and function. So we conducted a limited echo to evaluate the size and function of the aorta, along with carotid and femoral tonometry. And so we looked at multiple metrics of aortic hemodynamics, including metrics from pressure and flow indices, that allowed us to derive measures of aortic resistance, pulsatility, and stiffness, along with structural measures like aortic diameter. Similarly, we assessed carotid structure and function along with our colleague Chuck Tegler. So we used carotid ultrasound to visualize the common carotid artery, and conducted measurements at rest to, again, similar to what we did for the aorta, looking at various measures of pressure and flow, resistance, pulsatility, and stiffness, as well as structural measures, including carotid diameter and wall thickness. And so our key mechanisms of interest, again, focused on those integrated neural and vascular pathways that regulate blood flow to the brain at the local and systemic level. So we were interested in cerebral autoregulation. This serves to maintain constant blood flow to the brain despite fluctuations in blood pressure. And so the cerebral autoregulation works by responding to various myogenic and metabolic stimuli, by modulating resistance of the cerebral arteries or arterioles. So it causes vasoconstriction or vasodilation to in turn regulate blood flow. At the systemic level is the arterial baroreflex. This serves to maintain constant arterial blood pressure. And so this is really a network of organs that work together to modulate blood pressure. And so there are sensors in the aorta and the carotid arteries that detect changes in blood pressure, send signals to the brain that then responds by sending signals back out to the body, notably to the heart and the blood vessels, to modulate myocardial contractility, heart rate, and vessel tone. And so these are really important, particularly for transient or acute changes in blood pressure. For more chronic stabilization of blood pressure, the kidneys are also involved. But these systems work together to maintain blood flow to the brain. So our key vascular outcomes of interest really focus on understanding how blood flow, particularly potentially harmful blood flow, is transmitted from the heart to the cerebral vasculature. And so again, working with Gary Mitchell, who's worked extensively on this and published, we're able to take the pressure and flow waveforms for both the aorta and the carotid arteries and decompose them into their forward and backward or reflected waves. And then we can model blood flow through the proximal aorta and to the common carotids and measure things like carotid transmission coefficient and aortic carotid reflection coefficient that really reflect how much of potentially harmful pulsatile flow is being transmitted into the carotid arteries or being reflected. And so the idea is that the more that's reflected away from the cerebral circulation, the better, the less that's being transmitted. All right, so, oops, let me go back. Sorry. All right, so to summarize the larger clinical relevance of the Pointer Envy study, we know that arterial blood pressure is really the driving force for cerebral perfusion pressure and ultimately cerebral blood flow. And so this again is a connection between the arterial baroreflex and cerebral autoregulation to maintain this. And this ultimately has important implications for cognitive function. So with aging and disease, we know that the body has a harder time regulating blood pressure. And so this is evidenced by reductions in baroreflex sensitivity, increases in blood pressure variability, and sympathetic tone. Within the cerebral circulation, aging is characterized by increases in pulsatility and cerebrovascular resistance, which occurs alongside adverse changes in brain structure and function. Fortunately, many of these effects are modifiable. And so we know that things like physical activity and a healthy diet, which are two of the components of the U.S. Pointer interventions, can effectively improve or attenuate these aging-related changes. So I've quickly summarized the study design and methods for Pointer Envy. But if you want more details, I'd like to dig in a little bit more. I would like to encourage you to check out our paper that was published in Alzheimer's and Dementia in 2024. So Pointer Envy really was designed to answer three main questions. First, do the pointer lifestyle interventions improve baroreflex sensitivity and cerebral autoregulation? Again, those key mechanisms that regulate blood flow to the brain. Do the pointer interventions improve vascular function? And are these neurovascular outcomes associated with cognition and neuroimaging outcomes? For the purposes of this talk, we're just going to focus on baroreflex sensitivity and those key vascular markers that reflect blood flow to the brain. And so to test the hypothesis that the structured intervention would lead to greater improvements in these neurovascular outcomes compared to the self-guided group, we use linear mixed effects models with participant intervention assignment and time as the independent variables, and sex, race, and age and site as covariates. And then we compared the changes in these outcomes between intervention groups. So to hear the exciting results from this study, I'm going to pass it to my colleague, Hassam.
Thank you so much, Tina. Thank you so much, Matthew and Jenny and Heather, for the introductions and for organizing this. I'm happy to share the data that we have so far, and we have lots of data, so we're just touching the surface. So how did we end up enrolling our participant in Pointer Envy? So this slide summarized that we started with a 2,111 participant in the main Pointer study. And we ended up enrolling from 4 sites. One site we're not able to enroll from, which is the Houston site, because of logistical technicality. So we excluded 455 from that side because we did not have a study there. And we approached most of our participants at baseline, but we also approached some participants at year 1. Going from that route, we ended up having 440 participants enroll at baseline and 419 complete the visit at baseline. And they were split equally, like almost equally, between the 2 arms of the study, the structured and self-guided, which allowed us to compare between the effect of the intervention on those arms and maintain the randomization design that was in the main study. So looking at this table summarizes the difference, the comparison between the 2 groups at the main study and the overall study, how our Pointer Envy cohort compares to. And if you look at this table, you can see that there were almost equal. There was no difference between our sub-cohort of 491 and the main study in any of the measures like gender, race, or blood pressure, or even the cardiovascular risk factors. And even comparing the structured versus the self-guided, the point here that they were equally distributed. There was no major differences between any of the measures or the baseline characteristics between the two groups. So diving deeper into the measures of the cardiovascular, this table shows some of the neurovascular outcome of interest, specifically the bioreflex sensitivity, the first line there, and key measure autonomic function such as heart rate variability.
Did we lose Hassam? Tina, do you want to take it over?
Looks like he froze. Yeah. So this table shows some of our key neurovascular outcomes of interest. And so what we have here is the overall means and then the means by intervention group. And I think the main thing that we want to show here is if you look at this far right box that shows typical ranges based on published literature, higher baroreflex sensitivity is typical of younger, healthier individuals. Oh, you're back?
Yes, I'm not sure what happened. I think the internet just did not like me. So for this table, you can see that the bioreflex sensitivity measures were almost at the lower end of the normative ranges. It's like around 8 milliseconds per millimeter mercury. And also the heart rate variability was at the lower end, and the aortic pulse wave velocity was at the higher end. So this states this group of participants at a higher risk of cardiovascular outcome. Indeed, we have almost half of the participants showing arterial stiffness greater than 10 meters per second, and closer to 60% having atherosclerosis measured by carotid intermediate thickness greater than 1. And closer to 20% of the participants showed positive orthostatic hypotension when you change position from supine to standing, where pressure drops greater than 20 millimeter mercury for systolic or greater than 10 millimeter mercury for diastolic. So this is our primary outcome measure, which is the bioreflex sensitivity. And as you can see, we show that a structured group had a greater significant improvement in bioreflex sensitivity. It's almost around 14% improvement in millisecond per millimeter mercury, comparing to a 3% non-significant change in the self-guided group. So this table shows the results between the two groups, and the point here is to show you that there was no significant difference in the effect of the bioreflex sensitivity based on our subgroups, the redefined subgroups, and this includes gender, age, and ApoE positive versus negative, or different Framingham risk scores. As you can see that the intervention benefits all subgroups regardless. The only difference we saw that based on your baseline cognition, you may have a better improvement from in the bioreflex sensitivity if you started at lower levels. So that's actually gets you a greater benefit based on where you started. Additionally, this is also speaks to the consistency of our intervention across these measures. The only subgroup or subclass where we found an advantage or a better improvement in cognition or bioreflex sensitivity was those who have subclinical atherosclerosis benefited more from the intervention. Okay, digging deeper into more of the autonomic measures, this graph shows 3 different measures of the heart rate variability and blood pressure variability. The top 2 measures shows that the intervention improved the structure in the dark circles, both SDNN and RMSSD, which are 2 measures of the vagal tone. There was no significant change between the 2 groups in the blood pressure variability. So this shows that the effect was more driven through the cardiac changes versus the blood pressure or blood vessel changes. And this is another slide summarizing the effect that we saw on the vascular measures. So this slide shows that there is improved large artery vascular function. If you can see that the aortic pulse wave velocity was reduced or maintained at lower level, where it's continued to climb up in the self-guided group. And additionally, this speaks to the stiffness of the artery, which means in the structured group, they had elastic or more compliant vessel, aortic vessel. We're looking at the reflection coefficient, both the aortocarotid reflection and the global reflection coefficient, both of them continue to go up, which also speaks to more appropriate structure of the arterial circulation. Looking at the carotid transmission coefficient, you can see there is a significant improvement, which is a reduction in that transmission coefficient, where the self-guided group continued to go up, which is natural with age. Putting all of these together, this kind of a response leads to a more protective, which reduces the transmission of harmful pulse-style flow to the brain. So it's more protective to the brain with this kind of a structure. So in addition to the cardiovascular outcome, looking at our cognitive function changes to compare it to the main study, you can see, similar to the graph that Heather showed at the beginning, our ancillary study, although it's only in less than 25% of the total population, we still have a significant improvement in both groups, with a significant improvement in the structural group in the dark color compared to the self-guided, which is still statistically significant. Okay, looking at individual measures of executive function versus episodic memory and processing speed, these components of the cognitive function, all of them improved in both groups, with a greater advantage over intervention effect in episodic memory and processing speed, but still consistent with the main study that both groups improved, but there is still effect of the intervention. We looked at the intervention effect based on the baseline autonomic function to see if actually how you started affected how you improved after the 2 years of the intervention. We split the group based on their heart rate variability measured by RMSSD or baroreflex sensitivity as low and high quartiles. So we had the lower group versus the higher group. And we saw that the lower group had a greater improvement in their cognition, both those who have lower RMSSD or baroreflex sensitivity. So there was a more robust intervention effect in those in the structured group if they started at lower level of autonomic function. So in general, in summary for this part, we successfully enrolled a diverse group with older population that represents similar distribution of this US pointer and has moderate to high neurovascular burden based on their baseline values. And our comprehensive neurovascular assessment used the complementary non-invasive techniques. We're able to collect the data from the whole 420 participants that started at baseline with the additional group that started at 1 year. And the structured intervention led to significantly greater benefit, both at the cognition level and the neurovascular outcome. And next step, as Heather said, that we look forward to the extension of the study. Obviously, the main study already been extended for another additional 4 years. So we're still seeking funds to look what happens after they stop the intervention in the follow-up 2 years. So I will switch gear and move to the next question, which may be more interest for this group based on your research expertise, which is the blood pressure and hypertension. What happens based on how they started. And as you can see, this pie chart to the left side, it's the main study. To the right side is the pointer group. And this is the distribution of the 2,111 participants. You can see that only 20% were normal blood pressure when they started. 80% of the group, which probably was by design, have hypertension. And the two groups to the left, the bluish color and the pinkish color, are the ones who actually knew that they have hypertension and were in treatment. 20% only was controlled, 35% was not controlled, and there is 23% or 20% if you only look at the subcohort who did not know that they are hypertensive, they are not on any medication, but they still have high blood pressure when they started. So this obviously speaks to the consistency between the pointer in the group and the main cohort, but also speaks to the problem of awareness of blood pressure or hypertension, and how we looked further how this starting point can actually affect how do you respond, or what's the baseline cognition values that you have. So when we looked at this, and you can see the graph to the left is global cognition. You can see these two bottoms or two bars that are going down. They're actually the hypertensive group, and it's lowest global composite scores in the uncontrolled hypertension, followed by the controlled hypertension. On the other side, the highest cognition measures are in those who are not receiving any treatment, followed, or they don't have blood pressure. Actually, their blood pressure is normal, followed by those who are hypertensive, but they are not in a treatment. And we don't know why they're not in a treatment, and if they are aware or not, and how long have they been hypertensive. Similar pattern repeats actually in the executive function, and repeats even if you look at the processing speed and episodic memory, where you can see the lowest values are in the hypertensive group, controlled or uncontrolled, and even worse in the uncontrolled, and the highest values are in those who are normal pressure or not being treated. So this is how they started. This slide here shows how did they behave over the span of 2 years. What's the effect of the intervention? Self-guided in the light colors and dark colors are the structured. You can see that all measures, regardless where they started, the cognition measures improved in both groups, with significant improvement in all the measures regardless of the hypertension group. But also there was slightly more intervention effect in the controlled hypertension when it comes to executive function, and in the normal and controlled hypertension when it comes to global function. So putting all of that together, this diagram shows you that there was a favoring for the structured intervention in almost all the measures, regardless how they started at the baseline. The effect was evident in both of them. With that, I would like to acknowledge my co-PI, Tina, for great run for 6 years so far, and the rest of the team. And the red colors are the group at Wake Forest, and the other cardiovascular engineering support team, and our collaborator from Amsterdam who actually helped with the TCD and cerebral autoregulation, and the teams in the other 5 sites that participated in the study, and Alzheimer's Association for their funding, and NIA for their funding. But above and before all of that, all 2,111 participants who made pointer, US pointer actually happened. The participants were actually the backbone for all the study. They were very willing and continued with us across the whole time, and we had a great retention rate for the study. With that, I will open it for questions.
Great. Thank you very much, Tina, Hussam, Heather. I really appreciate it. Encourage everybody, if you have questions, to put them in the Q&A function. Let me get the questioning started by Heather, turning to you first. There was a mention on one of your slides that you didn't see differences or the effect of the intervention was the same regardless of age, several factors, and one of including heart health status. And I'm wondering if you can expand on that a little bit, and what kind of differences, similarities you saw with people with heart disease.
Yeah, no, absolutely. And so again, I mentioned that we use the FHS in terms of a baseline and characterizing individuals for their degree of cardiovascular risk, and with that we actually cardiovascular disease, and what we saw is that it didn't really matter where they were in terms of that overall assessment, that they actually still in later life, and we also looked at a whole lot of other things, so their blood pressure and a whole lot of other kind of factors in at baseline, and it regardless of where they were on that range, if that was a variable that was perhaps indicative of heart disease or not, we saw the same benefit or the outcome at the end in terms of the benefit of the structured intervention over self-guided.
And you mentioned a couple of other ancillary studies other than Hassam's and Tina's, and I think you mentioned sleep as one, which is always something that I'm interested in because I have sleep issues. But I'm wondering if you could just give us a quick summary of the other ancillary studies.
Yeah, so the sleep ancillary studies saw a similar benefit of the structured versus the self-guided intervention, with the seeing a reduction of the number of apnea events during an evening that individuals experience. So that the benefit of the structured versus the self-guided intervention was not just only on cognition or the measures that you heard the neurovascular group here report out, but actually also on sleep and a reduction of those apnea events. We are still doing some assessment of the sleep fragmentation data to see what may be some of the other outcomes, and we don't know the answer yet to some of those other related measures, but it does suggest that actually, this kind of circular notion of sleep and the impact of sleep ties into some of these behavioral interventions, likely ties into cognition, and it also may be that it ties into the overall cardiovascular health, right? Because there's also connections to overall cardiovascular health and sleep quality as well. So all of those things are interlinked with one another. The other ancillary, two other ancillaries, one is a microbiome that hasn't reported out yet. And so again, I think that will likely have some interesting data that may be of interest to this group in thinking about the gut-brain axis and the linkages there, which also we know has some tie-ins to the overall cardiovascular health of individuals. And then the third was looking at imaging. And so looking at amyloid and tau PET. And the big question was, in 2 years between structured and self-guided, do you see a movement on any baseline Alzheimer's related measures? And so looking at amyloid and tau PET specifically. And in the 2 years, they didn't see at the gross measures, they did not see a difference for those that had a baseline measurement of amyloid or tau PET in terms of a reduction of those. But what they did see is that individuals that had a reduced hippocampal volume, which is one of the brain changes that we often see early on, volume changes that we often see, areas of the brain that we see impacting in Alzheimer's, they actually saw a greater benefit on cognition of the structured intervention compared to the self-guided. And those that had a buildup of tau based on PET in the entorhinal cortex of the brain, an area that is also known to see some of these brain changes in Alzheimer's very early on, they also saw a greater cognitive benefit. Huge questions that this raises, but it does suggest that there may be something that building cognitive resilience or cognitive resistance with the structured intervention compared to the self-guided, even in the context of disease-related brain changes. And so, again, raises huge questions. It was asking a lot to see a movement on PET markers in 2 years of a 2-year intervention. So I think that's where, and I kind of alluded to this, but I didn't say it, I think that's where the continued follow-on of the participants beyond the trial becomes so important. And so we are continuing to measure those assessments of individuals cognitively as they've left the trial in the absence of intervention in the main study, but also look at continued imaging to say, what do you see in 4 years? And so maybe you don't see a decrease or a movement in that way, but actually do you see a lessened of a slowing of the accumulation? We don't know. Some big questions there. And I know Tina and Hassam are also looking at that long-term follow-up in their study as well. And maybe the last thing I'd mention and pass it to Tina and Hassam is that there is a group of people that were in all of these ancillaries that provide a really incredibly rich data source that, as we're doing some of this top line analysis, will allow us to ask and answer questions that there is no other population or no other kind of grouping of individuals that have been so deeply phenotyped will allow us. So I don't know if Tina has some want to talk to that.
Yeah, actually, I was going to add, the fact that we have all these ancillaries and there was a significant overlap between the 4 ancillaries in terms of participation. There are really great questions that we can ask. And we already know that, a lot of these neurovascular outcomes, vagal activation is important, is connected to gut-brain health, is important to inflammation. We know that, sort of the rationale for even doing neurovascular sub-study in the first place was because of the effect on cerebral perfusion. And so we have data from the imaging ancillary to look exactly at that question. Are these neurovascular outcomes predictive or associated with cerebral perfusion? And so I think, there's just such a wealth of data that we can interrogate to answer really great questions that I think no other study is really poised to be able to do. So we're really excited about some of the work that we've already started connecting the ancillary study data, but there's a lot more to do.
Great. So Hassam and Tina, I want to ask you, how would you translate your findings down to an individual level? So what should a clinician, for example, take away as from your study results so far as to what should they say to their patient in the clinic?
Okay, maybe get the big guns back again, Jenny, if you can put the slides back up. So it's not an easy answer because this is not blood pressure where physicians can actually look at the numbers that they have and have a step-by-step like upscale going for this one drug treatment. If it's not working, go to the next level and the next level. Butterfly sensitivity, and when Jenny puts the slides, is not that I cannot share. Okay, so butterfly sensitivity is not beyond the clinician at the clinical level yet. It's mostly research at the current level, but there are lots of studies actually linking butterfly sensitivity changes to dementia, to cardiovascular outcome, and I'm going to share some of them. But how they can act on it, that's a very political question, or a question that requires more work to first promote the study and promote the importance of butterfly sensitivity. Okay, this study actually looked at the butterfly sensitivity in 1,800 or 1,819 participants from the Rotterdam study. And we published this like almost a year and a half ago, where we showed that butterfly sensitivity tracks with incidence of all-cause dementia. And the higher their butterflex here in the blue color, that incidence goes down, the lower your butterflex. In this group, we split them into 5 groups, and this is the lowest in the red color, have a higher incidence, and this was a follow-up for 20 years. So the reduced butterflex was associated with high risk of dementia and associated with increased risk of death, almost like 76% increased risk of death if you are in the lower quantile. So that tells you how important this value. What does it mean from our study point of view? As I said, we had 14% improvement in butterfly sensitivity. Can we quantify that? How many years is this? Not based on our data alone, but based on other predictions that normally your butterflex goes down. And this is from healthy subjects, around 3% per year. So if you're losing around 3% per year, and if you as a sudden have a 14% going up improvement, that's as if you're reversing your heart health or autonomic function health by around 4 years. This was 2 different studies, 2 different age range. Also, we have to take this in consideration that at older age, your rate of decline may be different because it's not a straight line where heart health change on a constant level. Also, we showed that there was around 12% improvement in heart rate variability. Heart rate variability have been shown to be associated with sudden cardiac death. If you have a reduction, if you are at the lower end of the SDNN, you have immediately it shoots up, your chances of sudden cardiac death goes up. In addition, also higher heart rate variability have been associated with better performance in the MESA study. We published this almost 6 years ago from a 3,000 population, and this was done in almost 12,000. A meta-analysis that was published in 2013 showed that with every 1% increase in SDNN, your chances of improving cardiovascular outcome or reducing your chances of fatal or non-fatal cardiovascular disease goes down by 1%. Simultaneously, a 1% reduction in your SDNN increases your chances of arterial fibrillation by 24%. So if you reduce by 1 standard deviation. So in numbers, any improvement in your heart rate variability or butterfly sensitivity is actually significant improvement in your cardiovascular outcome and your dementia outcome. But can you tell a physician, let's measure butterfly sensitivity twice every year or every 2 years and see if they're declining or if they're not or stable? Really, it's hard to put this into perspective, but we know for sure from previous work that there are interventions that can actually improve butterfly sensitivity. One of them is what we're presenting today, the multi-domain intervention. Exercise have been shown to improve healthy diet, obviously, which is a part or a component of our pointer prescription, in addition to different antihypertensive medication. All of these are listed, and to the right side is references of how they can improve blood pressure and baroflex sensitivity. So it's not just controlling blood pressure, it's also having a drug that can reduce blood pressure and improve baroflex sensitivity and heart rate variability while at it. And there were studies where they looked at ACE inhibitors and ARBs being the major drugs they used for controlling blood pressure. There is a big difference between those who can cross blood-brain barrier versus not. So if I'm talking to a physician, if you're going to treat blood pressure anyway, maybe use one of those. Maybe use one of those drugs that can actually cross the blood-brain barrier and improving your chance of dementia. Like you can see, those ARBs reduce dementia by 22% as compared to any other antihypertensive. But those who received blood-brain barrier crossing had a significant improvement of more than 27%. So
Great.
I'm not sure what to tell a physician, because obviously we're not at the point where we can dictate what to do them, but we can provide our research to their use, and they can make their own decision.
Yeah, great. So we're almost to the end. There was a question. I know, Heather, you typed a response to it, but it's a really good question, and it's a question I have been asking a lot since the trial, and that's it's a slight variation on the question in the chat, but my question has always been, can you parse out individual specific of the interventions, pieces of the intervention, to determine whether something worked better than another? The question in the chat was, is there an effort on the self-guided group to see what their behavior change may or may not have been, to see whether they are really significantly different than the structured group? So do you want to quickly answer that? Because I think that's a really great question.
Yeah, I typed the answer because I thought we might run out of time, and I wanted to make sure I addressed it. But yeah, absolutely. Huge question and really important question. And within each of the groups, there's of course low and high and low adherers. So within the structured group, you're going to have people that didn't do all the components. And then you're going to have those kind of super performers. And in the self-guided, the same. You're going to have people that took the information, they didn't need the structure. They were able to actually, take the information that they were learning and translate it into behavior change. And that's just the science of behavior change. Is some people need a lot more handholding, a lot more kind of oversight, structure, and the goal setting and that accountability. And other people just need to be given the information and take it forward. And so in both groups, we know that there's some variation of what that adherence looks like and the behavior change that went into place. But obviously, we have the ability to measure that, and we had a lot of independent variables that allow us to measure this, so we can get into the how much is enough. So we can actually look at the components individually, but also see the synergy. It seems that the synergy does make a difference, but we're doing a lot of analysis on this to really look at that. And it may be that you get to a point that what's that look like? And so, being able to ask and answer that question. But I think the question in the chat was, so that's kind of to Matthew's question, being able to tease some of this apart. But the question in the chat, and then within that context to Matthew's question, how much is enough? So how much do you have to do? Do you have to do everything that was in the prescription, or can you do some variation of that and you still see the same benefit? The question in the chat was whether we also looked at whether there truly were differences in these groups. And the answer is yes, there are truly differences in these two groups in terms of the behaviors and the activities as measured across and throughout the duration trial. Recognizing, though, that there were some individuals in the self-guided that absolutely reached the levels of the structured, and there are probably people in the structured that may have been more on the activity level of the self-guided. So, but that's part of where the numbers and the power of the trial overall became really important. So I hope that addresses the kind of person's question.
Great. Heather, Hassam, Tina, thank you so much for a very informative hour. Back to Jenny to close us out.
Thank you all so much. This was so amazing. We will send out the recorded link soon after. And just a reminder, we will have another fireside chat in May to celebrate Nurses Week, where we will learn about nurses and their role in hypertension control. And a final note, the CDC Foundation launched a consumer-facing or patient-facing campaign, Hypertension Bites. And in part of the really long research and focus groups that they've completed over the last year, the number one thing that most people we're afraid of is dementia with uncontrolled hypertension. So we know this is huge. Thank you all for the incredibly hard but critically important work that you do every day. We appreciate you. I hope everyone has a wonderful afternoon and a great rest of your week. Goodbye, everyone.